Hello, happy Wednesday, everyone. Thank you so much for joining us this evening. We're super excited to be hosting this webinar. And if you've been experiencing TMJ pain or are looking for solutions to solve that clicking and popping when moving your jaw, you're in the right place. And we've got a ton of great information to share with you tonight. I'm Olivia with Ethos Integrative Medicine. I'll be moderating this webinar. Before we start, please remember to mute your microphones. If you have any specific questions, definitely feel free to type them into the chat. We'll be sure to answer them towards the end. If you have any specific questions pertaining to your personal care, unfortunately, we cannot address that tonight in our webinar. However, I highly recommend scheduling a free 15-minute consultation with Dr. Morgan Massingale, and she'll be able to answer your questions and help you to navigate treatment options specific to your case. So I'll go over more information about that in the end of this. So stay tuned. And first things off, I'd like to start off our webinar by introducing our Regenerative Orthopedics and Women's Hormone Specialist, Dr. Morgan Massingale. Her biggest drive and approach to medicine is to help her patients achieve short-term improvements while simultaneously building the foundations for lifelong health. Today, she'll be diving into common underlying causes of TMJ pain, associated symptoms you might not be aware of, and strategies to help you feel better. So we're super excited to have Dr. Morgan host this webinar tonight. I hope you all get the chance to connect with her. She's a fantastic resource. Without further ado, I'll let her get started with her presentation.
All right, thank you so much, Olivia. It's great to have people joining us this evening for this little chat about temporomandibular disorders, previously kind of known as TMJ. We're now kind of using the letters TMD because it does kind of encompass more than just the joint itself, but a lot of the surrounding structures around that joint. So I wanted to reiterate what Olivia said. Feel free to go ahead and type your questions in the chat. Every time I'm preparing a webinar, I always hope to make my presentation as clear as this nice instructor right here, 2 times 1 equals 2, 2 times 2 equals 4. Sometimes it's a little bit more like calculus or, some advanced mathematics, but I want to make sure that we don't end up leaving people behind. So if you have some questions or need some clarification on anything that we're talking about, feel free to type those questions in. We'll either address them as we go or at the end. So just a little introduction about myself. Dr. Morgan Massingale. I work here at Ethos Integrative Medicine. I have a Bachelor of Science and a Master's of Science from Georgetown University. And I spent 7 years working in the pharmaceutical research industry before I decided to go back to naturopathic medical school. And that is a story and a journey of its own. But after finishing naturopathic medical school, I completed a 2-year residency training in orthopedic regenerative medicine and image-guided injections. So let's dive into the meat of it. TMD, what is actually involved? Interestingly, it actually affects 25% of the adult population, affecting women at a higher rate than men, unfortunately, ladies, sorry. And the greatest risk of onset for this disorder or these disorders is between the ages of 18 and 40. That's not to say that, if you're younger than 18 or older than 40, you can't have these conditions, but just the majority of the patients that we see first develop these symptoms fall in that age range. There is an increased prevalence with rheumatoid arthritis, interestingly. And so if you have that, comorbidity, something to kind of think about. It is also associated with bruxism, also known as the grinding of the teeth as we sleep, an unfortunate side effect of that. And then some studies actually suggest that repetitive motion and position can be associated with developing these disorders, though the quality of the studies there is fairly low, but good to mention. If you're doing repetitive motions such as clenching, excessively chewing gum, biting on pens and pencils, especially if those actions really aggravate your symptoms. And then positionally, we're looking at people who constantly have their jaw in a fixed position, such as like scuba divers, violinists, singers with their jaws wide open, woodwind players, things like that, that's requiring a very specific movement pattern and positioning of the mouth and jaw. So we're going to jump into a little bit of anatomy. Don't worry, we're not going too deep a dive here. but just want to understand kind of the structures that are involved that we'll be talking about. First, you have the bones, the temporal bone and the mandibular bone, which makes up the temporomandibular joint right here. We kind of zoom in on that joint and see the articular structures that can be affected as you start to have any degeneration in these areas from prolonged disorder. Also involved are the muscles of mastication. So those muscles that are necessary to make that chewing motion. The largest of and most powerful of those muscles is the temporalis muscle, which kind of encompasses this whole side of the head area here and works to close the mouth. Actually, 3 of the 4 muscles involved here are working to close the mouth because it takes a lot of force to create chewing and that grinding action necessary to properly masticate or chew your food. So the masseter is the next one that is located kind of from here down to the bottom of the mandible. And then the medial pterygoid, which is actually deep underneath the mandible, as you can see kind of labeled in the pictures here. The only muscle really responsible for opening the mouth is the lateral pterygoid muscle. Again, that is deep to the mandible itself. And we only really need one muscle to accomplish this action because 1, there's not a lot of resistive force that we're driving against. And also, usually we're seated in an upright position as we're doing a chewing motion, and we have that benefit of gravity pulling our jaw open for us, right? The next thing to consider in our anatomy when we're looking around here is the innervation of this area. The trigeminal nerve is a nerve that actually comes straight from the brain. So it's one of the cranial nerves that then innervates the face. There are 3 branches to this nerve. And the area that we're considering here with TMD is the 3rd branch, so commonly known as the V3. The sensory innervation here, you're getting sensory input from the jaw, the lower lip, and also the gums. The motor input here is for those muscles of mastication that we just talked about, so providing that opening and closing action of the mouth. And also, interestingly, you have motor innervation to some of the small muscles of the inner ear. I tried to get some good diagrams for you guys, but because these muscles are so tiny, they're really hard to kind of visualize. You just have to kind of conceptualize where they are and what they do. But importantly, that motor innervation also provides innervation to the tensor tympani, which actually helps dampen loud sounds for us, and the tensor palati, which actually elevates the soft palate of the back of the throat and allows for that eustachian tube function, so allowing the draining from the ear into the back of the throat. So this is actually kind of the cause of the less recognized ear symptoms that are associated with TMD. So TMD, why me? Factors thought to contribute to TMD, joint trauma. This is pretty kind of self-explanatory. Any trauma to that joint can lead to early degeneration. But trauma can also arise from cervical strain. So any strain where you've had like whiplash type injuries, anything like that, because of the way that the musculature and also the connective tissue in the head and neck all comes together. If you have any movement patterns that are disordered, you can have stress on the jaw that's coming from other places. And that's where we get into this cervicogenic factors that are contributing to TMD. Poor posture can actually contribute to that, uneven distribution of force in the head and neck, leading to TMD. There are also thought to be contributions from pain threshold and processing disorders. So myofascial pain disorders that can actually lead to sensitization of pain of the central nervous system. And so you have small movements, small things that happen that create an increased response in the central nervous system that really needs to be addressed on a more kind of systemic level to get that to calm down. Then you also have psychological factors. Studies have shown a strong correlation between TMD, anxiety, depression, PTSD, and a history of abuse. So, when we have psychological factors that contribute to pain symptoms, it's a fine line between telling people that there's a correlation there, and that, it's definitely, as a holistic practitioner, I want to address the whole picture of what's going on, and making it sound like it's all in your head, because those are two very different statements. This is definitely not an all in your head situation. So TMD, what are the actual symptoms? I think classically we kind of recognize a couple of these: the facial pain, and then the jaw and TMJ actual dysfunction. So, the intermittent facial pain is classically recognized, but it actually can occur in some areas that you might not expect. So you might actually have symptoms through your sinuses, around your eye, into your ears, and into the back of your neck. Again, because of all the way of the movement patterns and the contributing factors and the way the musculoskeletal balance works there. Headaches can actually arise from TMJ. They usually present as dull, achy, continuous, and moderate in intensity. And they also tend to be worse in the morning. So headaches that are worse in the morning and tend to kind of lighten up through the day, though they don't really go away. This is thought to be worsened by that bruxism, or that overnight teeth grinding, because those muscles are so active, clenching and grinding while you're sleeping. These headaches can present as one-sided or, as both-sided. It actually can present in the frontal, the temporal, or actually the occipital region in the back of the head. And then we have those more classic, jaw and TMJ dysfunction symptoms that you might actually commonly think of: decreased range of motion, so not being able to open your mouth to that 40 to 50 millimeters that is typical. Clicking and popping of the actual joint with any jaw motion. Jaw deviation, so if you try to open your mouth, should come pretty straight down. With TMJ, sometimes you can have lateralization, where the jaw comes to the side as you try to open. And then worst case, we have jaw locking. When this starts to happen, the jaw locking can be intermittent, but it actually can progress to more serious and long-term jaw locking. So we really want to catch patients early and prevent that progression. The jaw and TMJ dysfunction also seems to be worse in the morning and get progressively better through the day. And that is, again, thought to be connected to the grinding or bruxism that is associated with TMJ. Some other symptoms to think about that are associated that you sometimes get overlooked: neck pain. And this is because of that relation that we talked about briefly earlier with that cervicogenic, or that neck etiology or beginning process of that dysfunction through the head and neck. Eye pain. Most people don't think of a jaw problem causing pain up into the eye. But again, that's because of the innervation that we talked about earlier, with these structures being innervated by that trigeminal nerve and having a common nerve root in the brain. Eye pain is usually one-sided, and it's described as like a boring pain when it is associated with TMD. And then interestingly, also dizziness can be associated with TMD. And this is because of the association and the affect that happens with the inner ear that really affects our balance and our sense of position in space. And when that becomes disturbed, you can have symptoms of dizziness. So you have TMD. What now? What do we do? Conventional treatment options, definitely, we want to talk about these. Patient education and self-care is highly effective in cases of TMD. And this usually comes from your dental health professional. They are best suited to make these sorts of recommendations with proper head posture, proper mouth posture, exercises that you can do to alleviate these symptoms, sleep hygiene, and then avoiding triggers. So if you are a nail biter or you constantly chew on pen caps and you notice that that's causing that pain or that clicking or that grinding, trying to avoid those triggering actions is hugely beneficial. Next is physical therapy. Because of the way we talked about the associated structures, all the way tension from the shoulders up through the neck into the jaw, getting the help of this physical therapist to properly position, posture, strengthen muscles that may have been weakened over time from poor posture and poor movement patterns, again, can be really beneficial in providing long-term relief from TMD. Occlusion splints are also an option. These definitely should be fitted by a dental professional after a proper evaluation for bruxism. So usually these are devices that you use while you're sleeping to prevent that grinding action. If all of these more conservative therapies fail, a lot of times patients will be prescribed or advised to use non-steroidal anti-inflammatory drugs, NSAIDs. So these are your over-the-counter, typically ibuprofen, Aleve, then you have prescription meloxicam, things like that. Short-term can be beneficial in bringing down the inflammation in the actual joint. Long-term use, unfortunately, we see linked to GI problems like ulcers. So we don't want to be on these drugs for a long duration of time. If all of that fails, some patients are actually prescribed skeletal muscle relaxants like cyclobenzaprine and metaxalone. These medications should be used with caution and definitely are prescription medications and can be sedating. So when you're starting these, making sure you're talking to your healthcare professional if they are appropriate for you and for your condition. And then kind of a last resort for most professionals here in the conventional realm are steroids. So you can do a corticosteroid directly into that temporomandibular joint. Steroids are highly effective at bringing down inflammation, and studies with TMD have shown that it can reduce or alleviate symptoms for around 6 months at a time. Some things to consider with steroid injections. Short term, they can actually cause some blood sugar dysregulation. So if you are already struggling with some metabolic concerns like diabetes or things like that, this may not be a great option for you, and you definitely would want to watch your blood sugars for a few days after you receive a steroid injection. That really goes for any part of the body. And then the long-term side effects of steroids, you actually start to see a breakdown of the articular cartilage from repeated steroid use. So like I said, short-term benefits, and if it's a one and done, that may be a good option for you. But if you're finding that you're needing to have these injections repeatedly to manage the symptoms of TMD, it may be time to talk to someone about some other options, just because we could be making the problem worse in the long run. So what's our approach? We really take into account all of the structures and all of the components that really go into TMD. So we're looking at the symmetry of the joint, how the joint is moving, also how the joint is moving in coordination with the other side. We may need to refer to some of our physical therapy partners if you're not already working with a physical therapist. Looking at the quality of that articulation, has this been going on a long time? Was it a secondary to trauma, which is one of the risk factors that we talked about earlier? Has that articular surface been damaged? We do have injection therapy options that really can address that. Looking at stability. Again, if you've had trauma to the joint, some of the ligaments that are supposed to do the static stabilization there could be damaged, and your muscles are overworking, causing increased problems. So we can address the stability of the ligaments there if that's necessary or part of your picture. And then also that neuromuscular component, right? So how do we get in there and address those nerves that have been affected? If you have clenching long-term, those muscles are hypertrophied or they're a little bit bigger. They're not allowing the nerves to glide, which causes nerve irritation, which causes a lot of those associated symptoms, right? The eye pain, the ear fullness, ear pain, neck pain. And when nerves get angry, they make their neighbors angry. They like everyone to join in on the fun. So that's where you really get a lot of those associated symptoms. And there are, a lot of options to address that. One, you want to address the actual muscle pattern firing to make sure that, everything's working appropriately. And then there's actually injection therapies that we'll talk about in a minute that can help bring down that nerve inflammation. And that's really, how we kind of build a treatment plan to give you your best treatment. Medicine is definitely not one size fits all. If there's somebody out there claiming to have the one treatment for TMD, my advice would be to run the other way, because there's not one thing that works for every patient. You really need a comprehensive evaluation, and we, work with our dental neighbors here at Smile Concepts to kind of get a really good diagnosis and then customize a treatment plan for you. We're also going to kind of stack the odds in your favor by talking to you about a few other things, right? So we're going to modify activity. We're going to focus on nutrition to make sure that if we're discussing regenerative procedures, things like that, that you have the building blocks to build new tissue. Do you need to go on some short-term supplements? Would it be appropriate for you to, address some nutrition things to help with cell signaling, to decrease pain, and also, increase tissue repair? All of those things are, what we take into consideration when we're building a treatment plan for you. So what are our treatment options that weren't listed before? First, prolotherapy is a kind of umbrella term for a lot of our regenerative injections, but most commonly it's used to refer to our dextrose-based therapy, which is a dilute sugar solution mixed with a local anesthetic. This particular injection therapy is best used to tighten ligaments and tendons. So if you're that patient that has TMD because of trauma to the joint, it may be appropriate to get in there and help stabilize some of those ligaments that were damaged during that trauma. Next, in our regenerative injection bag of tools here, we have platelet-rich plasma. So platelet-rich plasma has become a bit more popular, thought of a lot with joint restorations, also hair restoration, that sort of thing. But what is it actually? So what we do is we take your own blood, we spin it down, and we collect the portion that is rich in platelets and growth factors. And then we use that portion and inject it back into the site that needs a little bit of help to stimulate regeneration or repair. Can be a really great therapy, both prolotherapy and platelet-rich plasma, when it's appropriate in the case, right? The next thing we have to talk about is perineural injections. So unlike the regenerative injections we talked about on the last slide, which should be done by a trained professional that's done this multiple times, and it should be done under guidance. It's very difficult to palpate a joint that small and accurately introduce a needle without some sort of guidance. Here at Ethos, we use ultrasound guidance so we can see real time exactly where the tip of the needle is and where we're delivering any medications. Perineural injections, on the other hand, are more superficial. So we use a little 1/2-inch needle, our little baby needles, and really target any subcutaneous nerves that are affected. So if you remember back a few slides when we were talking about that trigeminal nerve, and you saw kind of all of the yellow spaghetti that was sitting on top of the musculature, those nerves run just beneath the skin and on top of the muscles. So they're fairly easy to access. Perineural injections itself is made of a dilute sugar solution, so a 5% dextrose solution, and it attaches to a receptor called the TRPV1 receptor. And in not to get super technical and bore everyone to sleep here on this evening, it's similar to hitting a pain reset button. The TRPV1 receptor is the same receptor on nerves that responds to topical CBD, topical arnica, topical capsaicin, those sorts of things, but actually really helps reset the chemical signaling that is sending that pain signal back up into the brain. Also, through a property called Hilton's law, we can affect deeper structures by injecting superficial nerves, which is a really powerful component of this particular type of injection therapy that gets overlooked a lot. So if we're injecting those nerves that are supplying the muscles and the joint, it actually can, through the retrograde uptake of the solution, provide that reset or that calming effect to deeper structures without having to go deep into a joint. So I hope this provided a good overview of TMD, the associated symptoms, and kind of some options that you may have that you may not have heard of yet. Would love to, if you have TMD or have any questions about TMD, send Olivia your information. She can get you registered or booked for a free 15-minute consult, so we can just talk about what is going on in your specific case, and discover what treatment options might be good for you in particular. It's also a really good opportunity to meet me and get to have an interaction with the physician, because part of the healing process is that that one-on-one interaction with your provider, making sure that they're hearing you and that they're addressing everything about you appropriately.
Perfect. Well, thank you so much, Dr. Morgan, for hosting this webinar. It was really interesting to learn about the different factors that may contribute to that TMD and different treatment strategies that can help with that. And thank you so much to everyone for joining us today. This is a recorded webinar, so if you missed the beginning or you want to go back and watch a section, a specific section again, we will be sending this to your emails that you use to register for this. So keep an eye out for that as well. You can also share it with a friend that you might know who is experiencing these kinds of symptoms and want to get some help for that. And I hope you learned something new as well from this webinar today. And if you take anything away from it, I hope that you understand that if you are experiencing pain, you don't have to live with it forever. There is a physician out there who will take the time to understand your specific situation and work with you to create a solid treatment plan that's best for you and your lifestyle. So I'm going to open it up for a couple minutes. If anyone has any questions, definitely please type them into the chat. We want to make sure that those are answered here. If you have any general questions about anything you heard about tonight, the treatment strategies Dr. Morgan brought up, we can definitely answer those, or you can go ahead and private message me. We'll reach back out to you. We can schedule you for that free 15-minute consultation if you have those specific questions regarding to your personal care. We can get you set up with Dr. Morgan. So we look forward to connecting with you soon, and definitely stay tuned to our email series as well as our social media. So our Instagram, we'll be posting more content related to TMD, as well as the many exciting events that we have coming up at our office. We've got a Shed the Dead chemical peel event. That is why my face is looking the way it is. We've also got a special zombie outbreak challenge that we're doing to walk to our grand opening event, and our grand opening event is on Thursday, November 11th. So mark your calendars for that. We'll be sending out more information, and we'd love to see you there and connect with you there as well. But in the meantime, have a great rest of your week, and thank you again for tuning in tonight.
So we had a quick question that I just wanted to address from Vicky. She had asked, does full ears mean just feeling full, or does it actually affect hearing? You can actually do both. Because of the way that that nerve affects that dampening muscle, it can kind of dampen the level of sound that you're receiving from that side, affecting, you know, how well you're hearing, as well as that fullness sensation.
Perfect. Did anyone else have any questions tonight? Again, I just want to reiterate, I will be sending this email out to, or sending this webinar out to the emails that you used to register tonight. So keep an eye out for that. Those will go out hopefully tomorrow night, if not by Friday. So keep an eye out for those. And definitely, if you have any questions, you can call our office. I put our number into the chat, and you can Google us as well if you can't find that. Our information is there as well. But thank you again for tuning in tonight, everybody.